good afternoon. Thank you for being back. And my name is Chris Lehmann, and I have the opportunity to moderate this session, which is very exciting. The first speaker will be RaeAnna Jeffers, who's a registered nurse and a health science librarian at the University of Texas at Arlington. Her experience includes 14 years of bedside nursing and a health informatics degree from the University of North Texas. And she's planning to return for her PhD in health informatics in January of next year. Ms. Jeffers' passion is to find reliable ways to get highest quality research and information into the hands of doctors, nurses, and other practitioners at the point of need. So without further ado, I'll turn this over to Ms. Jeffers. Thank you.
Very good. Thank you. I appreciate you inviting me to come and speak to you today. I'm honored to be here to discuss a topic that I'm really passionate about, and that is guidelines. So without further ado, we'll get going. So throughout this talk, I will pose questions to stimulate thought about the complexities of issues involving guidelines. Many are good research questions, but the literature does not have consensus to answer them fully. However, sharing them with this community could spark an interest in looking at these elements to build a better support system for our healthcare practitioners. I hope you'll join in. I'm here to advocate for this body to actively promote open access to high-quality guidelines. Guidelines inform evidence-based decisions in all facets of our healthcare system.
Ms. Jeffers, we can't see your slide.
Oh, I didn't share. I got so excited, I just jumped right in.
Thanks, Catherine, for jumping in. So,
Thank you so much. Sorry.
We can see your screen.
It's the wrong screen. There we go. Let me just back up and catch up again. So I'm here to advocate for this body to actively promote open access to high quality guidelines. Guidelines inform evidence-based decisions in all facets of our healthcare system. Guideline adherence is part of our professional scopes and standards of practice, yet frequently paywalls block us from accessing the very documents required to meet scopes and standards. This is a pay-to-play schema where the publishing body requires subscription or membership to either the publishing body's organization, the individual publication, or to just pay outright for the individual published guideline. Those fees, depending on the practitioner, may be too prohibitive no matter which level of access they need. Libraries typically offer and support using an interlibrary loan service to request access, but the turnaround time for those can be days, and that depends on the type of request being asked, the volume of requests coming in at each lending institution, and the availability of staff to field these requests. Healthcare providers cannot wait days, they cannot wait hours, minutes matters, and we need solutions now. So here's a question. What if a clinician does not have access to a library that can fill the information need? So this is already happening to clinicians all over the country as medical and hospital libraries shutter their doors. Budget cuts, digitization, and moves toward virtual services are some known influences for this trend. According to the National Libraries of Medicine, in 2007, there were 3,166 medical libraries in the registry. That number declined to 2,140 in the span of a decade. That represents a 30% decrease in medical library availability. We do not have the data to know the extent of the impact this is having on patient care, outcomes, costs, and practitioner satisfaction. So here's another question. When guidelines on a topic exist from different agencies, how does one choose which to pay for, access, and evaluate if all you can see is a brief abstract? So let's just imagine for a minute that you're one of those unfortunate folks that doesn't have access to a medical library to fill an urgent need for a guideline. So what happens? You decide to pay to play, right? But wait, there's more. Duplication in efforts in publishing guidelines creates redundant or conflicting advice. Redundancy speaks to a lack of transparency in the system and a need to redirect those resources elsewhere. Like this highway system, we need a directed flow from creation to dissemination. We could create a registry for guideline proposals, much like we do for systematic review protocols to help with the transparency issue. We also need to prioritize guideline development to begin systematically addressing our highest needs. These two measures alone could conserve our resources in developing guidelines. Conflicts exist between different organizations who publish guidelines. So you might have two different organizations who publish guidelines on a specific topic, and the advice in those guidelines conflicts. I see this in my practice, and sometimes the conflict makes the entire guideline completely useless because you can't determine which one is the correct one a lot of times. So, and it's pay to play also in medical, academic, and hospital libraries. They make strategic subscriptions and negotiate packages to publications based on an allotted budget and prioritize needs. Not all budgets are equal, hence access to content is not homogeneous across institutions. So here's another question. Who does this exclude? How does this affect patient care quality, outcomes, costs, and job satisfaction? These are substantial questions that do not have answers yet, but I'm confident we have eager researchers in the room today who would like to help in that regard. By now, you're probably wondering, what about clinical decision support tools? Don't they have guidelines? I'm glad you asked. I understand the utility of clinical decision support tools and support the idea of creating tools to help with workflows. However, this is still a pay-to-play schema. Software companies package guidelines as part of the allure of purchasing their product. However, if you have access to a medical library and a clinical decision support tool, you may be paying for that guideline more than once if your library holds the subscriptions to the publications that contain the guidelines. Unfortunately, sole providers may not be able to afford a single instance of the software. So costs may be prohibitive for some institutions, especially if there's an electronic health record integration that's necessary. Another point is that each product sources their information in different ways. Some companies hire medical staff to synthesize research and make recommendations based on their findings. I looked into some of these boards and observed that medical librarians are largely absent from that process. As a registered nurse and a librarian, this scares me. So here's a question I would like you to respond to in chat. On a scale of 1 to 10, 1 being feeling totally lost and 10 being expert, how confident are you in your search skills? So enter your response in chat and we'll monitor those as they come in. Other companies source guidelines by scraping the journal publications that they own themselves, along with content indexed in Medline. This is essentially a repackaging of their core product, journals. So here's another question. If a company only sources from their own publications and Medline, how does that influence guideline development, implementation, and outcomes? What roles does open access research play in guideline development? So far in my work to elucidate these concerns, I'm finding that open access research is largely absent from this conversation. If there are open access journals sourced, there are few. The trend in the sciences is a push toward more open access content. The research should be included in the guideline development process. Before I wrap up, I would like to share with you the reasons for my passion on this topic. I worked in bedside nursing settings outside of the hospital environment for years. I have firsthand experience on how difficult it can be to get your hands on guidelines. As a health sciences librarian at the University of Texas at Arlington, I help my students find guidelines regularly. The College of Nursing and Health Innovation enrolls just over 15,000 nursing students for this academic year alone. Roughly half of those students are already registered nurses who are finishing their BSNs or graduate degrees. I have a large cohort of nurses in our community who are working on the front lines during COVID-19 response. These poor students and nurses are spending hours searching for guidelines, and that is just absolutely unacceptable to me. So let me take you through a journey. As it stands today, this is kind of the process that my students who are nurses, a lot of them, are going through to get to their guidelines. So first you get on the computer, you search for organizations that might publish a guideline on your topic. You find a website that looks promising, so you access it. Then you have to figure out what journals are being disseminated by the organization by hunting and pecking in the various tabs and menus. With the publication name finally in hand, you then run a search in the library's holdings for the journal title. Next, you search within the journal for the guideline topic. Sometimes you find a good one. Many times, however, they are old, and they're older than the recommended 5-year span. Now you have to obtain access by connecting through the library's item link. If that fails, we then try to find it via Google Scholar. If there isn't an open copy, we process an interlibrary loan request. Finally, once we have the guideline in our hands, we can determine if it's going to help us with the problem we are working on. Unfortunately, when we get guidelines, they don't always help us with the problem we're working on. So we've just went through all of this process, and we have to start over again. Help me make sense of this mess, you guys. This mess, y'all. It's going to take the whole of us to get movement toward open access to guidelines. Thank you for indulging my soapbox moment. If you're interested in helping, please consider completing this short 7-question survey. At the end of it, you will be provided with a link to a Google Sheet to begin organizing to work on these problems together. And in the chat, I'm going to pop in. Let me get my chat open again.
So we have a few numbers in the Q&A that you'll be able to see. There were a lot of responses in the chat, but you won't be able to see those, unfortunately.
Oh, okay. Let me stop sharing. Did everybody get the QR code? I'm about to drop these in chat for you. There you go.
Thank you very much, Ms. Jeffers. And if I may, I'm going to ask the first question, and we have limited time.
Sure.
Not all organizations are equal. have you found, I know I'm a pediatrician, so I know the American Academy of Pediatrics makes their guidelines open access. Can you point out some other organizations that deserve a gold star for having these policies already in place?
Actually, the American Academy of Pediatrics is one that I would definitely endorse. I'm really still investigating all of these organizations. This is a fairly new problem that I'm working on solving. I've been aware of the problem for a good while, but as far as vetting each institution as to the level of access they provide, that work has not been done yet on my part.
All righty then. Since we are short on time, I don't want to cut in the time for the next presenter, I'm going to go ahead and introduce him. Again, thank you very much for presenting. And our next speaker is Dr. Jakub Furmaga, who is an assistant professor of emergency medicine at the University of Texas Southwestern Medical Center. His areas of interest include bioinformatics, medical toxicology, drug testing, and laboratory medicine. Without further ado, Dr. Furmaga.
Hello, everyone. My name is Jakub Furmaga, and I'm here to discuss with you an implementation of a homegrown, non-interruptive clinical decision support tool, which we developed to improve physician documentation here at UT Southwestern Emergency Department. This project was performed with Chris Lehmann, Jason Ott, and Sam McDonald. So disclosures, no conflicts of interest. We did not get paid to perform this study. And most importantly, I am not a billing expert, but I did speak to many when performing this project. So objectives, we will identify some of the automatable elements of physician documentation. We will describe the implementation of complexity box, which is the name we gave to our clinical decision support system. And then we will describe the impact that this complexity box had on physician billing and coding. So introduction, first we'll talk about the problem itself. So physicians do perform a lot of functions. We take care of patients. We make sure that our departments are compliant with guidelines, both from within our institution, but also federal government. And then we document what we did and why we did it. And of all the things that we do, documenting in the EHR or electronic health record is probably some of our least favorite things to do. However, coders, they heavily rely on our provider notes to assign CPT codes, which are current procedural terminology codes. That's how a lot of reimbursement is driven by these codes. In emergency medicine, we have a number of E&M codes, and those are evaluation and management codes that kind of designate the patient complexity, with 99281 being the lowest and 99285 being the highest complexity. To make things more difficult, each CPT code has its own documentation requirements. And as you can imagine, the higher the complexity code or encounter, the more requirements it has. This is a sample table to kind of help summarize in a very succinct form what the requirements are. As you can see, the elements of history, review of systems, past medical history, family social history, exam system findings, and then medical decision making. All these play a role, and each complexity, each code requires various elements in each category in order to qualify for this. So kind of setting this problem up, it is very easy to see that incomplete provider documentation can lead to downcoding of even the most complex ED encounters. And we've seen this a lot. So we tried to figure out, can we automate some of this documentation to minimize these problems in the future? So then we went back and we looked for potential automation candidates. We examined Clemens Emergency Department billing data for the first 6 months of 2019. During that time, we noticed that there were almost 4,500 patient ED encounters, during which time patients had received intravenous or intramuscular opiates or benzodiazepines. And if you look at official guidelines from Center for Medicare and Medicaid Services, or CMS, they considered administration of intravenous or intramuscular DEA-controlled medications, such as opiates and benzodiazepines, as highly complex because of their potential to cause respiratory depression and therefore requiring additional monitoring when administered. So when looking at these 4,500 encounters, we noticed that 3/4 of them have been coded at the appropriate CPT code of high complexity of 99285. But 1/4 of them, 25%, were coded at lower levels, even though they should all have been 99285s. So if you actually do the calculation about what the difference in RVUs, which is relative value units, or how much, how we get paid for our services, this comes out to 1,300 RVUs in that 6-month period. So what does that impact, you ask? So in 6 months, if you translate those RVUs, what we usually bill for, this comes out to $213,000 for a 6-month period, and you can extrapolate that to about $427,000 per year. That's just billing. And then based on reimbursement data, based on percentages of billed and how much we get paid, this comes out to approximately $172,000 per year. And this is for work that was already done but not reimbursed. So then once the problem has been identified, we look for solutions. And our solution was to develop this non-interruptive clinical decision support tool, which we called Complexity Box. So what Complexity Box does is when patient presents to ER, it looks through all the medications that were administered during that given encounter. It filters out and pulls out all the intravenous or intramuscular benzodiazepines or opiates, and then it makes a table, as is kind of shown at the bottom of this slide, and it drops this table at the bottom of ED provider note. And we chose the bottom because this is an area of the note that has minimal clinical value or content. Providers that write the note rarely look at that area, and other providers looking at other physicians' notes also don't really look at that area. However, coders do pay attention to it, so that's why it was mostly designed for coders. Again, to emphasize, this complexity box required zero effort on the physician's part. This automatically populated into the note. And as you can see on the bottom, this is an example of a morphine. This is kind of important because it not only populates information when the medication was administered, but also shows how much was administered and through which routes. And this is very important because morphine comes in both oral and intravenous forms. And oral morphine is something patients take at home and obviously doesn't require as much monitoring as when the medication is given intravenously. So when physicians usually write in their note, patient got morphine, the coders cannot extrapolate this to say, hey, this was probably the intravenous one, which requires extra monitoring, therefore is more complex. They couldn't assume this, and this automatically provides that information for them. So once we came up with a solution, we wanted to see whether this is actually going to make a difference or not. So we designed a quality improvement project where we examined all the Clemens Hospital ER encounters in the month of November of 2020 that involved administration of intravenous opiate or benzodiazepine. And so of all those encounters, we actually used electronic health records to randomize patients into 2 arms. One arm was patients' notes contained the complexity box that I just described, and the other arm within the study contained just standard notes. So it did not have the box on the very bottom of provider notes. Our outcome was to compare the absolute count and the percentage of E&M CPT codes, like I described earlier, the ED complexity ones. But we also decided to include critical care CPT code. And that's because whenever somebody meets critical care criteria, the standard E&M codes are substituted and the critical care one is used instead. So let's talk about the results. This is the table number 1, like in all publications. This shows the demographics of our study groups. As you can see, the randomization divided them pretty evenly into 2 equal number of patient groups. So there were about 375 and 370 in each group. Mean age in each group was very similar. Also, gender distribution was also very similar, with 58 to 61% females. And then mean ESI, which is Emergency Severity Index. So this is an index. When patients present to ER, it automatically shows their chief complaint and age, like how severe their complaint is. And this is a 5-point scale. 1 is being most severe, 5 being the least severe. And as you can imagine, both groups had patients with similar severity of illness, if you will, because their ESI was 2.5, about 2.5 for both. As far as medication distribution, the top 2 agents used in each group were opiates. So hydromorphone is also known as Dilaudid, and morphine is morphine. So those were kind of the top 2 in both categories, just swapped, but they are used interchangeably. And then the third agent was a benzodiazepine, lorazepam, or also known as Ativan. And again, that one also had similar percentages. So those were the descriptions of the groups, and this is the actual results of what it showed. So this is a table that shows the rows are the CPT codes. The first one, 99291, is the critical care, and all the other ones are the E&M CPT codes. And if I could bring your attention to column P, those are basically, it shows whether there is a significant difference between the 2 groups. As you can see, the 99285, the complexity box had significantly higher percentage of 99285s, and it also had a significantly lower percentage of 99284s, implying that complexity box helped correct 99284s to the correct 99285s. This is just a graphical representation of the data before. As you can see, the complexity box it even looked significantly more 99285s and less 99284s compared to the standard note. And then during our analysis, it was brought up that does coding at a higher, do the higher codes, appropriately higher codes, do they actually correlate with better reimbursement? Meaning, are insurance companies or payers, are they agreeing with our new CPT code, and are they actually paying for the services that were rendered? So when we went back and looked at the financial information, it turns out that complexity box group had both higher mean invoices, so that's how much the bill was, and the invoice was higher by $18 in the complexity box group, but it also had higher reimbursement, and the reimbursement went up by $8 in the complexity box group compared to standard no group. However, if you look at the 95% confidence intervals, yeah, the mean invoice was higher and was statistically significant, but the reimbursement, even though it was $8 more, the 95% confidence interval crossed the 0 mark, which means it was not statistically significant. But if you kind of break those down into more granular information, it turns out that there was a large number of no pay encounters in both groups. So 106 encounters in complexity box had $0 as payment, and 110 in the standard no group. And what that means is that this study was basically underpowered to detect this difference in reimbursement. Interestingly, when I went back in and removed all the encounters that had 0 in reimbursement, so no pay, the complexity box reimbursement, so how much university got paid, actually went up, was different by $40. So 40 more dollars on average for complexity box. And actually that was statistically significant. This slide is just a graphical visualization of the previous data on the previous slide. So both of these are kernel density estimate graphs. And this is a method of visualizing the distribution of observations in a data set. And one easy way to kind of describe it is it's smoothed out histograms. So on the left graph, this is the total invoice. As you can see, the complexity box had much higher rate of invoices higher invoices, basically invoices with bigger amounts. And that kind of makes sense because the CPT codes on average were on the more complex side. And then if you look on the right graph, and I don't know if you can see my pointer, but as you can see, there's a huge percentage of 0 payments in both complexity box group and standard note group. But then if you kind of get away from the 0 mark and you look, so the standard notes happen to have a higher rate of lower reimbursement amounts, meaning closer to 100. But if you look at the higher reimbursement amounts, so moving past $300, the complexity box actually had higher frequency of higher reimbursements, if you will. So even though again, this is the reimbursement is not statistically significant, if you eyeball it, the two groups do deviate and kind of spread apart on the higher end. And again, it's because of all the 0 reimbursement that kind of make this less significance with our test. So in conclusion, non-interruptive clinical decision support increases the complexity and final coding by a significant amount compared to standard note practices. And this was a small intervention which potentially has very large impact. So not only did it reduce the amount of time that physicians had to document, because again, the complexity box was populated automatically with no increased work from providers. This again, providers appreciate that because they don't have to spend as much time documenting. It also improved appropriate attribution of care that was provided. And again, so our department and our institution very much appreciates that. It increased revenue generated, which increased revenue generation, which is appreciated by our department and our institution. And it also increased the time.
Can you please wrap it up? We are running out of time.
Yeah, sorry. This is okay. So the future, we have since expanded the complexity box to include other medications such as blood products, intravenous cardiovascular medications, and insulin. And we continue to add more every day. Any questions? Sorry about that. There's like an alarm going in the back.
Yeah, thank you very much. But we have run out of time. And if you reach out to us and have any questions for Dr. Furmaga, we'll be happy to pass them on. But I have to pass it on to the next session, which is